Right. Well, welcome everyone. Thank you for being here today. My name is Daniela Gonzalez Rios, and I am the Health Justice Coordinator at AJE. I would like to take this moment to introduce the rest of my team. Alongside me in the Health Justice team, I have Dr. Chioma Ru and Amilka Hudson. Welcome everyone. If you need any support, you need to reach out or communicate with one of us, please feel free to message Amilka and he will assist you. And as Renee just did, please introduce yourself in the chat as you are coming in. We would like to also note that on the toolbar of your Zoom, you have an option that says transcript. So if you would like captions throughout the Zoom, you can select that option. I also do want to note that we have a live binder. Chioma, can you please drop that link in the chat when you can? This live binder includes all of the resources, the one pagers, the bios of our fantastic speakers, and also any presentation slides that you may need to reference with all the heavy topics we are discussing. We know it can be a lot to process at one time, so feel free to browse through that on your own time when you can. So, this evening, we will be learning more about Medicaid and alliance, especially with many of the policy shifts that are going on and will continue to impact the District of Columbia. So, before we get into the panel, I would like to take a moment to note that throughout the panel tonight, we will be just checking in with you all, asking a couple of poll questions just to get a gauge of the room. So at this time, I'm going to also pass it on to Chioma, who will lead some opening remarks and support us with that.
Okay, good evening, everybody. Again, I'm Chioma Oru. My pronouns are she, her. I hope everyone is doing well today. This is day number 5 of the health policy camp. And I'm going to be very quick. I just wanted to give an overview of a few things, and I will share a few brief slides. Give me a second. Okay. So, as Danny said, we have the live binder, and just a little bit, I'll back up a little bit about AJE for those of you who may not know. I know we have some new faces today, so I'm just going to keep repeating it. AJE was founded in '96 by 2 law students, 2 UDC law students. One is a fourth generation Washingtonian. Our mission is to empower families, youth, and community to be effective advocates to ensure that children, particularly those with disabilities and special health care needs, receive access to appropriate education and health services. Our approach is three-pronged. We have our direct services aspect, which includes our parent support, a family support specialist, which is a peer support program that are led by people with lived experience that are also familiar with special education policies and also safety net programs. And also our direct services includes legal services, which is specific for special education. And, cases only escalate to the need for legal services that we can take on, at the most critical level. So our most consistent support for families is through our family support. But we are very grateful to have staff attorneys to help in that regard, as limited as we are in that capacity. Our training, we also have trainings, and our trainings are part of our technical assistance offerings. We do trainings for parents, we do trainings for professionals, and there are many different ways that it can look. We have different TA models depending on the team that is implementing it. For us as our health justice team, our focus, of course, is on health and healthcare access. And so we are the health information channel. So lots of our trainings have to do with that, how it connects with all the other determinants of health and the systems of care. And we are excited about a future of offering technical assistance, particularly to those who are delivering services to families of children with disabilities based on our community needs assessment, which we won't go over right now, but we are happy to present that anywhere that we can. So, and systemic advocacy, that's also part of the work we do as the health justice team, is to be able to engage on systems work. Our team doesn't take on direct cases, but we are informed and will be able to refer to our family services should you need direct support or in a critical stage. But we do systems work in terms of engaging in local policy, health information dissemination, school engagement, community engagement, and just building relationships and a strong base of our parent ambassadors, many of whom are on here now, and this is considered their orientation and training. So, parent ambassadors, when you're introducing yourself in the chat, please note that you're a parent ambassador. We want you to stand proud and strong in your identity as we're growing in that. And just a little bit about the Health Justice Project. It was founded in 2021. We have been the federally designated family-to-family health information network for the District of Columbia since 2017 or 11, sorry, I believe. But in 2021, we decided to take on our Health Equity Project, which we renamed to Health Justice Project, to align with the current political climate because we are federally funded, we are government funded. And so injustice is, I feel, a more radical concept anyways. So we're okay with the name change and hope that it resonates with everyone else. Our focus is on words 8, 7, 5, and 1 in the original concept of the project. And in 2023, we included word 4. So we're very excited about the future of this project. It's beyond the 5-year scope when we originally thought about it. So today's agenda is on DC Medicaid. So we're having two panels, or I guess it's going to be more like presentation and Q&A because we have one panelist. I'm very excited about today because it's going to be a lot of useful information. Not that anything else isn't useful, but I think this is so directly impacting all of our lives that, I hope that this is as transformative for you as understanding what's happening is transformative for me. So the first topic we are covering is DC Medicaid and the impacts that the One Big Beautiful Bill Act. I have other names for this bill, but we're just going to call it by its legal name in this moment. And then we're going to have another panel looking at the future of the DC Alliance Insurance Program. And if you don't know what that is, we will go over that in a minute. And this is our agenda. It's just the standard agenda from last week, where what we're doing now is our opening, and we will pass it to our speakers. We'll have moderated conversation and then Q&A. And we hope you fill out the evaluations even as we do have to. I've put in the chat the live binder link, but you can also QR code it if you want to, or look at the short link to access our camp materials, as Danny mentioned. And our panelist today is Melissa Bird. Our first panelist is Melissa Bird, who is the Senior Deputy Director / Medicaid Director of the DC Department of Healthcare Finance. And you can see Melissa's full bio in our live binder. And we also are joined by Jen Jenkins, who's an attorney and policy manager working with Legal Aid DC to talk about Alliance. Our next camp session, and if you can please, Emil or Danny, please drop in the chat the registration link. Our next session is Thursday. It's our last panel. It's not a panel, sorry. It's a workshop. It's a facilitated workshop, and they're going to be 2 AJE staffers. So for all the PAs, those of us who have children in the home or youth in the home, this will be an important session to talk about youth transitions and transition from a expansive place, going from early intervention to secondary transition into adult services. And just a quick overview, it's going to be led by AJE's newly minted youth coordinator, the very first youth coordinator we have at AJE, Nyla. And then our next workshop will be on mutual aid for disability justice. We keep us safe. Also by an AJE staffer, one of our family support specialists, and that is Salima. So very excited about that. And then on Friday, I guess we might as well put that in the chat as well. If you want to join us, and it's parents only, caregivers only, because it's a parent cafe and we're going to be sharing intimate, confidential things, and we want to create that level of safety by making it a very peer and horizontal space. So anyone is welcomed that can wear the caregiver hat, and we're excited to have you all potentially join us on Friday from 11 to 1 at the Modern and Art Place. And details will be shared once you register. And thank you for posting in the link. So I just want to give a quick overview. I know that Melissa is going to go quick in depth about, you know, Medicaid and DC Medicaid specifically. Medicaid is a national program. It looks different in every state. So how these changes of the Big Beautiful Bill will impact Washingtonians will vary based on our state implementation of that federal law. And so just some quick things, things that we've gone over with our Community Health Advisory Panel previously in our March session. And this is just bullet points I got from different articles. And so I'm sure Melissa's much more is going to give us a bigger, deeper dive on these things. But just Medicaid accounts for over half of all long-term care spending. That includes home care, that's home care for children with special needs, senior care, adults with disabilities, but particularly for children with disabilities, it ensures that they can stay at home, because not too long ago, our kids were being institutionalized in places like Forest Haven, and there were not supports and services in the home. I'm just coming from MLK Library, where the Office of Disability Rights, DC Office of Disability Rights, is celebrating the 35th year anniversary of the Americans with Disabilities Act, and they were recapping on the sordid history of Forest Haven, which was a reality for little children, young adults. And so it could have very well been our reality if not for the key provisions that were implemented in Medicaid and then locally enhanced throughout the country. And so Medicaid, in addition to CHIP, covers more than 4 in 10 children with special health care needs, compared to 1/3 without. So a lot of American children with disabilities and without are Medicaid dependent. Medicaid is the only source of coverage for 1 in 3 children um, with special health care needs, and another 9%. So I'm going to let Melissa kind of go deeper into this. I'm going to stop sharing my screen here. But before we get into Melissa's panel, we do have some preliminary poll questions. So please indulge, and I will be interjecting from time to time when Danny prompts to go over the polls. So our first poll is going into the Medicaid workshop or panel, rather, is this. So if you can see it, please take the time to fill this out. It says, before today, have you heard of the One Big Beautiful Bill Act? We just want to kind of get a good sense of where folks are at with this bill. If you've heard of it, if you know about it, and it looks like majority of people have heard but don't know the details. So 5 people said that. And yes, and they understand it well. One person said no, and it's perfectly okay. Please feel no shame about it. It's by design that you may not know about it as much as it impacts us. We're at 61%. Our goal is always 75% response rates. Please, please, if you haven't responded to the poll, take your time to do it just now. And then I will share it with you guys in just a second. Yeah, 900 pages long. Oh, wow. You're going page for page. Kudos to you, Ebony. So this is the results from the first pre-panel question. And so let's go for the second pre-panel question here. And it is Mm-mm. Scrolls are all over the place. All right, so the question is, how confident do you feel navigating Medicaid changes that may impact your family currently, based on what you know? Um, and let's give a minute. All right, folks are the majority, highest numbers, people are somewhat confident. We only have one person that's very confident, a couple of people that are not confident, and and a couple of people that don't understand Medicaid. So you are in the right place. And we are building community here. And I will say that I'm very grateful to Melissa Bird because not only is she our DC Medicaid director, she takes her time to show up in the community. I've had community baby showers, and she showed up personally. She's part of a community health advisory panel. I just very grateful and know that she's going to be part of your communities too, which is part of having her here, and the continued partnership that AJE will have as part of our health justice project. So this is that. I will stop talking and I'm going to pass it on to Danny to introduce our panel and spotlight Melissa.
Thank you, Chioma. Well, you did a wonderful introduction for Melissa. And like Chioma said, her bio will be also available on our live binder. But I do want to formally introduce Melissa. She is a Senior Deputy Director and Medicaid Director of the Department of Healthcare and Finance. So throughout her career, Melissa was demonstrating strong leadership in public health administration, healthcare reform, implementation, and program management across multiple states. In her current position, she advises on major policy and budget issues related to the Department of Healthcare and Finance, healthcare programs, leveraging her comprehensive background in both public and private healthcare sectors. So I'm excited to hear a little bit of what Melissa has to share, and I want to pass it on to her to share her opening remarks.
Great, guys. Thank you so much. Melissa, as I was introduced, my pronouns are she and her. And just first, a couple initial comments. Thank you all for the warm welcome. It's great to be with everyone here this evening. And I feel like some of the statements that Chioma made in terms of talking about the big, beautiful bill and what folks may know or may not know, one of my opening remarks was going to be a disclaimer that we're still trying to figure it out too and don't have all the answers. So I think there's a lot of reasons for that. But please don't feel one way or the other about how much you do or don't know. It is something that, as I keep trying to remind folks, I'm like, it's only been like 20, 15, 16 days since the bill was passed. So we're at its 900 pages, like Ebony noted. So we're all figuring it out. I think it sounds like most everyone has some familiarity with Medicaid here in DC, which is fantastic. We do provide healthcare coverage for about 40% of district residents. That includes kids, adults, people with disabilities, people at end of life, people at the beginning of their life, and all in between. One of the things that I think is really important and that I've talked about a lot at the beginning of the year is I had to talk to folks on the federal side about some proposals about Medicaid, is that 60% of our spending really goes to child, behavioral health, and long-term care services here in the district. And I think it's important to talk about it that way because oftentimes when folks hear about optional services, in which many of these services technically fall under in the Medicaid kind of terminology, I don't think many of us would really consider them optional, like prescription drugs, like the supports that you need to be, in your home versus an institution. Next Wednesday is the 60th anniversary of the Medicaid program. And one thing that I've really been thinking a lot about over the past couple months as we think about what was Medicaid 60 years ago and today, and that kind of deinstitutionalization, you really see that kind of evolution with from the Medicaid program, whether it's with individuals with developmental disabilities or mental health or substance use disorder issues and so forth. So I'm excited to be here tonight to talk about, I generally call it, I think, the reconciliation bill. I may call it reconciliation. I may call it OBA. OB3 is sort of fun and easy. And so any of those mean the same thing. And please, at any point, if I use an acronym or something that you just doesn't make sense to you, feel free to flag me. I'll do my best to not use acronyms. We love them in Medicaid. And we'll talk through. I do think as we step into this, like I mentioned at the beginning, so the bill was passed or signed into law on July 4th or 5th. Now I can't even remember. And there were a lot of last minute changes in that last week. And then really it was, I think about a week later or several days later that we actually saw the legislative text. So I can tell you as of a couple of weeks ago, we were still identifying some things that changed from some of the draft versions to the final. But there, as this can feel like there's a lot of change happening, which is true, I do have to highlight that there are some wins in the sense that if you were following DC Medicaid issues over the past few months, there was a fairly concerted effort to reduce our federal funding for the district's Medicaid program, something called our FMAP, and changing that from the federal government paying 70% of our Medicaid costs to only paying 50%. And that would have been significant. I just really don't know how it's just really was not fun to think about what the program might look like with that kind of financial hit. But when we got to the final bill and really when it got to I think the Senate side, that provision was not included. So we're maintaining our normal funding, which is a huge thing to acknowledge. A couple other areas or things that were talked about a lot at the very beginning of the reconciliation process was like, do we block grant Medicaid or do something called per capita caps? Again, these would be just kind of like a structural change or foundational change to how Medicaid is financed, and those did not come through. So those are kind of what I think are some of the positives, if you will. The final one also being there was until the very end, it looked like there would be a penalty to states if they used any of their local funding to support healthcare for folks that may not be U.S. citizens, and that provision was also removed and not included in the final version. That's really important to many jurisdictions, certainly here in the district. That would have really brought some difficult discussions and questions about the Alliance program, because we would have essentially been penalized about $100 million if that penalty went through. So I like to, I always like to look at the bright side, and I do want to acknowledge those are some good things that did not end up in the final bill. I can pause for a moment, and then we can jump into what is in the bill, or however you guys would like to move forward.
Thank you, Melissa. We appreciate it. And for giving that background a little bit to some of the glows that there are, and focusing a little bit on that. So with that being said, let's get into the first question. Could you talk about a little bit of the specific changes that are happening in Medicaid that are proposed in the OBA bill? So how might that be improving or harming the services specifically for people with disabilities?
Sure. I would say, as I was trying to think about how best to categorize or break it down, I would say there are probably two big buckets that are going to be impactful to DC Medicaid. And for individuals with disabilities who are children, I think they will be less impactful than to adults. And then there's one piece that will kind of be impactful across the board. So I'll break that down a little bit. If you followed the bill or started reading some things on it, you'll see a lot of references to expansion adults. The expansion adults, this is the group of folks that we could cover after the Affordable Care Act. So when you hear Obamacare or ACA, you might think about how Medicaid expanded to finally give states an option to provide coverage to adults. In the district, we had already expanded our coverage to cover more parents or caretaker relatives, as we call it in the Medicaid nomenclature. But then we were able to also expand coverage to what we call childless adults. So just folks that don't have kids, because Medicaid is based so much in like children or parents. So that was the delineation. What OBA does for expansion adults is kind of three new provisions that are fairly significant, I think, in terms of just even from a philosophy or a policy perspective to the potential impact on individuals. So for expansion adults, again, this is for us, going to be people 21 and older. And most of our adults, with an exception of a small group of parents that are what we would call Medicaid, our mandatory population. And so starting by the end of so December 2026, Medicaid for expansion adults will also, for eligibility, have a work requirement. You might hear community engagement. It's all the same thing. And the requirement is that in order to, or I should say, in addition to meeting your income requirements for Medicaid, you will also have to show that you are working at least 80 hours a month. The definition of working is broad in the sense that it can be 80 hours of work, it can be 80 hours of some kind of community service. If you're in school, your time in school may count for those 80 hours as well. And so that's something, and this is an area that I will say, even as a Medicaid office, we have more questions than answers at this point, I think. We don't have any more guidance from the federal government than what is in the legislative text right now, but it's still something that we're focused on in terms of figuring out how do we implement such a new change and make it as, easy as possible for residents in the district to meet that requirement. That's the one thing. We've had 2 states kind of go forward with work requirements before now, and that's Arkansas and Georgia. And what I've read in terms of like the real challenges is not having the right communication or enough communication, and for folks on Medicaid to understand, does this affect me? Do I have to show this requirement? How do I meet the requirement? How do I show I've met the requirement? Kind of cumbersome on paperwork. So the kinds of discussions we're having internally already is, fortunately, we have apps for District Direct. So how can we make things as simple as, do you need to upload a document? Could you do it from your phone? That could satisfy something like that. How are we going to connect with the Department of Employment Services in the district? So if they have information that's available, we can use it electronically and try to check box as much and try to minimize as much of the lift on residents as possible. There are a lot of exceptions to the work requirement for adults. When you look in the legislation, and I'm going to pull up, I got to have some notes to make sure I capture everything for you guys. So give me just 1 second. There are mandatory exceptions. So if you are a pregnant woman, foster or former youth, a veteran with a rated disability, someone that is, and this isn't completely clear, but it says someone with alcohol use or substance use disorder treatment, you should be accepted from the work requirement. If you meet work requirements for TANF or SNAP, that should check box your Medicaid work requirements as well. A couple key ones, I think, for you all is if you're a parent or a caregiver of a child that is 13 years of age or under, you will be exempt, or the work requirement doesn't apply to you. If you are a person with a disability, the work requirement doesn't apply to you. And then if I said pregnant woman earlier, we have 12 months of postpartum coverage. And if you are in that postpartum phase, the requirement doesn't apply to you either. The other exception is medically frail. There's no definition, it's not defined, but what will happen under medically frail is that states get to set the definition for medically frail, but it has to be approved by the Secretary of the Federal Department of Health and Human Services. So we don't know how it's going to be defined. I know our approach will be to be as our definition will be as representative as possible of the people that we serve. So that'll certainly be the approach that we take, but no sense of what the federal government might be looking for at this point in time and how states create that definition. So work requirements is a huge change for Medicaid because it's never been required. It's been required for other programs, but it really has been, up until now, kept away from you must work to get health care. So that's changing a bit for a subset of people or district residents on the Medicaid program. We are trying to look right now and try to get a sense of the impact across the board. And we have about 285,000 residents enrolled in Medicaid. I think I think the subset of individuals that might be impacted, and I say might because it's before we apply, like, are you a parent of someone that's 12? I think we're looking at, around 100,000 or so, and then that pool will narrow from that point. But again, this is all early stuff for us that we're starting to look through. The two other things I'll cover real quick, and then I'll take a pause on work requirements and in expansion adults, if folks have questions, is starting in, now I'm forgetting my dates, guys. There are so many dates and I just can't remember them all anymore. And so I apologize for that. But in, I think the end of, no, give me a moment. I'm going to look this up so I don't tell you something wrong. But one of the changes that the OBA bill also makes is that, again, for expansion adults, right now, Medicaid renews, you have to renew Medicaid coverage on an annual basis. And then with the changes under the Big Beautiful Bill is that for expansion adults, the recertification process or renewing your coverage will go from 12 months to 6 months for those adults. So again, it's adults, expansion adults only. And of course, I can't find the date. I'm so sorry, guys. December 31st, 2026. So work requirements and 6-month recertification for expansion adults only is effective December 31st, 2026. The third and final kind of, I think, really big change from the bill for Medicaid for expansion adults is then cost sharing. So right now, states get to choose whether they ask or require cost sharing. What is cost sharing? Cost sharing is you need to pay $1 for your prescription, or you pay a $5 copay for your doctor's visit. In DC, we only have the cost sharing for prescription drugs, and then I believe for glasses as well. And it's like a $1 or $2 copay for each of those. The cost sharing provisions in the bill requires that for most services, that some form of cost sharing is applied. So somewhere from $1 to $35. And again, it's for expansion adults. And there are exceptions to that as well. So certain services, like going to a primary care visit, there is no cost sharing. We cannot apply cost sharing there. If you're getting your service from a federally qualified health center, so like Unity or Mary Center or Community of Hope, you cannot have, there is no cost sharing there. So it's up to states to determine how much to set the cost sharing. Again, it has to be more than $0. So $1 and no more than $35, or no more than 5% of a person's income, I believe. Given the districts, I think our position up to now on cost sharing, it has been nominal. I would expect that we would probably align with that going forward as well. And then finally, I said I was going to say two things. Once you move off like the expansion adults umbrella, if you will, then the next kind of big area that I think could be impactful, probably would be most likely to new folks coming into the program, or if for some reason you had a gap in your coverage, or like you dropped your coverage for some reason, is a change to the retroactive coverage policy. So what's retroactive coverage? Today, if I walked in and applied for Medicaid, what's today? July 22nd. I'm coming to Medicaid because I need some help with my health care, because I have been accruing some bills. I've had a new health issue pop up, and I've been to the doctor a lot over the past, like, let's say 6 weeks. Wait, right now, anything from today to 3 months ago, I can ask for Medicaid retroactive coverage. And if those services I received are Medicaid eligible, meaning it's, services we cover, then I can get reimbursed for that coverage, anything I've spent out of pocket. In the OBA, it changes that to only 1 month for expansion adults. So those adults I've talked about, those parents and non-parents across the board, changes it to 1 month. And then for everyone else, it changes it to 2 months only. So we will have to figure out how that's going to work. That is something that doesn't go into effect. I think it's a January timeline. Yes, it's a January 1st, 2027. And so And again, to kind of, if you were tracking the bill overall, at one point, retroactive coverage was completely eliminated. And then it came back, and then it came back again with this delineation between expansion adults and everybody else. So I'm going to pause because I just talked a lot. I don't think I've seen any questions. Oh, yes, I see Ebony. A lot of times you've deemed non-compliant, not eligible to the app and its malfunctions. And Ebony, I don't know if you're talking about the DC Medicaid app or work requirement stuff, but I've, at least on work requirement, I've certainly heard that. And then if it's talking about specific experiences with the DC Medicaid application, please feel free to direct message me on the issues that you may have experienced. So I'll pause for just a moment. So that's the really big stuff from a Medicaid perspective that we will be looking at and working towards implementation over the next several months.
Thank you, Melissa, for breaking it down.
Yep. And real quick, I have a question from Fari about expansion adults. Expansion adults is, it's just like such a poor name, right? It's Medicaid expansion, and Medicaid expansion, it was the legal authority that was provided through the Affordable Care Act or Obamacare that then let states choose to include parents at a certain income and adults without kids in the Medicaid program. So before expansion, if you were an adult without kids between 19 and 64, no disability, Medicaid was not an option for you at all. So if you think back, and you may hear from the next panelist on the Alliance program, the history of the Alliance program. If you look at the Alliance program prior to like 2011, the Alliance program was the district's program to provide some kind of coverage to adults at a certain income level. That it didn't matter if you were a U.S. citizen and district resident, or a district resident but maybe not a U.S. citizen. It was the avenue for coverage for folks. And then once expansion happened, folks that may have been on Alliance or an adult who may be coming in for coverage could then go to Medicaid and get Medicaid instead. And that was a good move for the district. It provided more federal funding, but also Medicaid has a more comprehensive benefit than the Alliance program does as well. So I'm sorry if I wasn't clear on that. A question from Michelle: does mental health day program count as work? That is a great question. I don't know at this point, but I'm going to make a note to make sure that we consider that as we kind of go through what does or does not count towards that. It kind of makes sense why it would. To be honest. But Michelle, thank you for mentioning that.
I'm loving the questions, and especially as we are reflecting. So for sure, if you have any questions, drop it in the chat. And Melissa, thank you so much for doing such a great job at immediately responding to them as well. I did want to get a little bit more specific about the type of services and how they will be impacted. So how does the bill expand across to services like home and community-based care? Or could it limit eligibility or shift funding away from those core supports?
So I've thought a lot about that just in preparing of a lot of, at least I know what I read over the past few months, really honed in on some of these questions. And so I think for the district, I don't see where there is a direct impact to services and supports related to long-term services and supports. So that's a really long-winded way of saying, like, I don't see why at this moment, because of the reconciliation bill, we would see changes to the kind of services and eligibility that's available for folks now that may have a disability. To now step back, and why I think we saw a lot of this during the discussion, the debate of the reconciliation bill, is something that has not a direct tie to the services, but is a financing mechanism that a lot of states. So you may have heard a lot about the provider taxes or state directed payments. And we have those in DC. But largely our provider taxes and the way we structure something called these state directed payments, happy to explain, but I don't know if folks really want to know about it. It really is supporting rates that we pay providers. In other states, and this is why you saw so much debate on provider taxes, states can tax a provider group like hospitals or nursing facilities. Those providers pay the tax. The state may use some of that tax money to then get the federal Medicaid match, but they also might use some of that money for something else because it's a revenue, right? And so when you see the changes to provider taxes, and so specifically in the bill, they're limiting the amount that states can tax hospitals. If a state is using some of that revenue to support its overall Medicaid program or something else in the state, they're going to have to fill that hole when they can't collect all that revenue. And I think that is where then really come in the questions and concerns about, well, essentially, is a state going to have to cut their program, or are they going to be able to fill in with revenue funds? So I think that's some of where we've heard that larger discussion about how is it going to negatively impact people with disabilities in DC. I think those changes in the way we use provider taxes won't have that impact for us. I hope that makes some sense. Provider taxes is something I don't always get it myself. It's extraordinarily or it can be complicated, but I really do think that I've tried to figure out like, why am I not having that same response to some of the things I read in the news? But I really do think it's related on some of those financing pieces that won't hit the district in the same way that it might impact other states.
Thank you, Melissa. In the chat, Rhonda asked if you could clarify what the definition of medically frail would entail.
I wish I could.
And I know you mentioned the states would be up to deciding, but you said the secretary. Can you continue?
So Rhonda too, and I think, hi Rhonda, I think we've met before. I'm sorry if I'm misremembering that, but no, we don't know the definition of medically frail yet. It's not prescribed in the legislation. It is up to the state to just to set that definition. But the state can define, but then the Secretary of the Health and Human Services from the federal agency has to approve that definition. So no answer yet. All I can say is our approach will to be to define medically frail in a way that is representative of the folks that we serve.
I just didn't know if you had some suggestion or ideal of some variations of that, because that's kind of broad, right?
Oh, totally.
And so it's like, okay, disabled. Well, we have some that, there's guardianship, you know what I'm saying? So what, I'm wondering of how to pinpoint it eventually might be, you know what I'm saying? And if you had any ideals of what that might look like, because that is very, very
it is very broad. And I think, as we haven't jumped into the weeds yet on this one, but like if I were to sit down with my team now and say, let's start thinking about this, where we would start is like, let's look at, the requirements and the exceptions. And once we go through the exceptions, like not who is left, but what is left that maybe impact someone's ability to meet that 80 hours a month, that we haven't, that is not addressed in these other things. And I think that's kind of the approach we would take. I think we will also look at, this is just normally how we do it. Like we're going to look at the different diagnoses we see on claims and the different data that we have. And that's where I think, we will try to tailor it again to make it as reflective of our residents and the folks on our program as possible.
If I could just add something to that, and when you have that moment that you're going to be thinking about those definitions, one of the problems that we experience with some of our families is that we have young adults that desire to work, right? And are not able to find a job, even if it is working with Rehabilitation Services Administration, right? So there's a group of young adults sitting at home, not wanting to, but maybe they didn't have a job coach that worked appropriately with them. So that's a big group. And then they also expanded, which the ability to get adult disability services. So there is the group of those with developmental disabilities, not all, but a good group of those with autism, that are now there, but through adult services, there may not be the jobs that are really available, and the supports to have the employment is a big piece too as well. So just kind of think those, don't
I
forget those
appreciate that.
things.
But that also just reemphasizes the conversations to have with our sister agencies as well. And then obviously through, groups like AJE and the advisory panel, making sure that we're bringing those forward as well. So thanks, Rhonda.
You're welcome. Don't forget the Family Support Council as well, which you've been with us.
Yes. Yep.
All right, thanks.
Thank you for that plug, Brenda. So, Melissa, I actually want to expand on Rhonda's question.
Okay.
Could you talk about how does the bill include meaningful support for youth with disabilities as they enter adulthood, specifically employment, housing, and healthcare continuity?
Um, I, I was talking to my colleague before this just to make sure I was not missing something. I'm not sure that it does. Specifically. So, and maybe that's the maybe you know that answer, and that's part of the point. I don't think it addresses things like that, but on the kind of opposite side, if you think of it from a different approach, I don't think it didn't add new restrictions to us in that respect. The one area that was kind of a surprise addition, like it seemingly came out overnight, was that there is a new provision that's effective in 27 or 28 that allows states to implement something we call the 1915C waiver. So if you're familiar with either the individual and family supports waiver or the individuals with developmental disabilities waivers through DDS, that's a 1915C waiver. 1915C is just a statute in Medicaid world, and so we call it a 1915C waiver. And then we have another one, the elderly and persons with disabilities waiver here in the district. When a state decides to do this 1915C waiver, it has to individuals, kind of a baseline eligibility requirement is that you have to meet an institutional level of care. And that's just always been the way, even for another avenue called 1915I, you still have to have this institutional level of care. Well, one provision in OBA, it allows states the option to apply for, implement what we call that 1915C waiver without meeting that institutional level of care. So, so that's kind of a huge policy change in the Medicaid world. On that front, not sure what that's going to mean or look like. There's not a whole lot of detail in the legislative text, but that's something that we'll be looking at just to understand what it means and what are the options under that. So I would say, Danielle, that's one potential option that might be more supportive of individuals with disabilities than without OBA.
Thank you, Melissa. And since we are cutting it short with time, I do just want to end these questions off with, could you just give us some insight with the efforts you all are doing at the Department of Healthcare and Finance right now? What suggestions you all are just trying to lead to create a more equitable system, including the bill passing?
Sure. My take on this, and I know we've talked about it a little bit, it is, I think, first and foremost, the area where we have the most opportunity to move or better embrace an equitable program is, having lived experience is what we call in our world, having people who are on Medicaid or their family members or caregivers at the table with us and giving, perspective and input and feedback, because that really, in my reading on equity work, having the voice is I think foundational. And so if we're going to make changes that, or incorporate policies or make changes to the program, I think we can do best by the folks that we serve by making sure that we're listening to the people who we serve. So that is kind of a foundational piece, which we have been focused on in terms of just doing better outreach, trying to make sure that any of our groups, particularly like where we've seen this the most is through our maternal health advisory groups, of really making sure that we have individuals that might, represent providers, that represent maternal health, moms on Medicaid, and women who have had babies and had the experience of going through maternity care in the city. So that's a huge way. One thing that's coming up in the district, and all states have to do this. We do have something that's called our Medical Care Advisory Committee, and Chioma has been on that committee for 2, maybe 3 years now, I think. And we have, because of federal rulemaking, we will be setting up something called the Beneficiary Advisory Committee, that's just very specifically focused on the individuals who are on the program and bringing that voice in through a routine way. So our Medical Care Advisory Committee has always had a majority of beneficiary advocacy on the group. Not every state apparently has done that. And so that's where you see the Beneficiary Advisory Committee. But I encourage folks to be looking out probably closer to fall for more information on how to join that. Another effort that we've undertaken at the department is finally, I think we started in December of last year, of having some compensation to beneficiaries or caregivers who are participating on that Medical Care Advisory Committee. I'm just acknowledging the value of the contributions and noting that, like, it's my job to be there. May not be your job to be here. You're being a parent or an advocate for your loved one or your family member, and it might be giving up something else in order to do that. So those are just some really small steps that we've taken, but still committed to it, and hopefully you'll be improving upon how we do these things.
Thank you, Melissa. Well, now I'll open it up to you all. If you have any questions, feel free to come off mute or drop it in the chat.
I don't have a question for Melissa. I just wanted to state that I am very interested in either joining the Medical Advisory Committee or the Beneficiary Advisory Committee.
I
But
will
just-
make sure.
Just
We
wanted
will
to put
reach
that
out
on your
to you
radar.
one way or the, in our MCAC, I think we just closed today or tomorrow for MCAC
Yeah, the
application.
application closes today at 5.
Okay, thanks. But we will, Faria, I will make sure I get you connected. I can do it probably through AJE when we have our Beneficiary Advisory Committee information come up, and make sure you have that. And then in the future, Chioma or Danielle may already get it, but I'll try to remember to make sure that when we open up our application process for MCAC, that we share it with this group as well. Okay. So thanks for that. Thank you for your interest.
Thank you.
Thank you. Chioma, I'll pass it on to you for this poll question. Oh, did you have a question, Linda?
Yeah, actually I do. I joined really late, so I missed a lot of it. But I'm really, as the person before me said, I would like to join that committee, but I hear it's closed. That transitional period where they're transitioning from from pediatric to adult, that's a real vital period. And I would really love to, I'm interested in learning that process and helping out with that, because my daughter has already gone through it. And I know it isn't something that just happens. It's a continuation of it for, the process isn't just a one shot. It's a process, and you have to continue on for a while. And so I really like to stress how important it is when they're especially if they have that medical piece, that critical medical piece, to get it as make it as simplify the process as much as possible. That's what I'll say. So yes, I'm really interested in that, because if that doesn't go right, it's a lot. It's a lot to do after that.
Well, Linda, thank you also for your interest. The positive thing is we are usually looking each year for new members of MCAC, and I think the Beneficiary Advisory Council may be on an annual basis as well. So I've gotten your name down as well as Fari's, and we'll make sure that we connect as things come out. But if you have, any questions or issues outside of that, and before I leave tonight, I'll make sure my email's in the chat, but folks should feel free to reach out to me as well.
Yeah, because like I said, the biggest piece is that when your child requires that medical piece throughout their lives, and how does this bill affect them, the medical piece? And like I said, I joined late, so I didn't get a sense of how it affects them through this process.
And not knowing, details matter in this case, but just from kind of, high level, I don't believe if a child has a developmental or physical disability, particularly if they have, their SSI, I don't expect there would be a huge change for them in terms of what their Medicaid coverage is. But again, details always matter. But generally speaking, it would be more impact if someone falls into that, what we call that expansion group. And again, those are adults with kids or without kids that are only eligible because of their income, not for any other reason. So that hopefully narrows it down a little bit, but that's my guess there.
Okay. Thank you.
You're welcome, Linda. Thanks.
And Linda, I did want to make a quick plug that we will be talking about youth transitions on Thursday at 6 p.m. So if you would like, you can definitely sign up for that as well. You'll get a chance to meet our youth coordinator at AJE, who will be doing a lot of this work. She started about a month ago, I believe. Her name is Nyla Morton. So we are definitely trying to take more ideas, and we would love it if you can join us just so that we can work collaboratively and see what we can do, continue doing.
Yes. Just send me the link, please. And
Yeah.
I will get on. I had a hard time getting on this time, so I think it's a little easier now that I've done it. So yes.
Got it. We got you. Thank you. I'll
Okay,
take note of that.
thank you.
Well, thank you so much, Melissa, for being such a great panelist and speaker today. We really appreciate all your time. And thank you for also sharing your information, and anyone who would like to reach out to you can do so as well.
I'll be hanging around. But thank you guys so much. I always appreciate the opportunity to speak. And again, we'll have more information coming out over the next several months on the different changes to Medicaid. And then in just a moment, I'm going to answer Shioma's question in the chat, and then I'll put my information in there as well. And folks should please feel free to reach out. Okay.
Great. So while you do that, Chioma, I'll pass it back on to you to lead that poll before we take a mini break.
Okay, great. Before I stop spotlighting, we're going to do 4 questions. 2 are going to be relevant to Melissa's panel, and the next are going to be relevant to Jen's panel. So I'm going to keep Melissa spotlighted for these first 2 questions here. And let me go back here. So okay. And I see what's happening. All right, sorry. Can you see this question now? And it's what potential impact of the Big Beautiful Bill worries you the most, kind of based on what we've heard just now? Stricter Medicaid eligibility requirements, reduced funding for disability services, barriers to behavioral or dental care, which we didn't quite go into that, but if that is a concern, we'd love to know. Confusion or lack of communication about changes. Hopefully that's not one of them. Well, I stand corrected. Please feel free to be very authentic in your answers here, or you're not sure. So we have 44% response rate, please. Add your thoughts. We'd love to get to at least 75%. We're at 66. So it looks like the majority of people so far are saying reduced funding for disability services are their top concern. And the next from that is stricter Medicaid eligibility requirements. I'm going to end this poll and share this. And one more question from Melissa's session. And that is, do you feel this panel helped you better understand how to protect your child's Medicaid rights? Yes, somewhat, not really. I still need more info support. Looks like we are between the yes and the somewhat. We like that. One, not really. Okay. Two, still need more info support. That's why we're here. We are building intentional community for health information. Stay close, and we'll try and help support in whatever gray areas may still be looming after today. All right, 61%. I'm gonna let this open for just a few more seconds, please. Take time to answer it if you haven't yet. We'd appreciate your response. All right, gonna stop and share these results and then stop sharing. And thank you, Melissa. I'm gonna stop spotlighting you, and then let's get Jen on here.
Thank you. Melissa, I feel as if we didn't even touch on the basic health plan. And if you mind, could you just share some notes, or if you can come off mute?
Sure.
Yeah.
Yes, I know. I caught that at the end too. So there is the big beautiful bill that is federal in Congress, right? But there are some changes through our local legislative process through the upcoming fiscal year 26 budget that's impacting Medicaid. The biggest one of the well, Jen's going to talk about the alliance changes. The biggest change on the Medicaid side is that we are changing the eligibility income for adults. So right now we cover most adults. Again, this is in that kind of expansion population, if you will. So they're adults or parents that are eligible because of their income, not because of a disability or something called like a mandatory category. So individuals, right now we cover most parents or childless adults up to just over 200% of the federal poverty level. And that will come down to 134% of the federal poverty level. What will happen is there is going to be a new coverage option that's going to be implemented in the district, and that's something called the Basic Health Plan. I believe it will have a different title at some point, but Basic Health Plan is an option that states have through Obamacare or the Affordable Care Act, and it provides what's called marketplace coverage. So if you're familiar with DC Health Link or the Health Benefits Exchange, it's through that entity within the government. And so the Basic Health Plan option will have benefits that are similar but not quite the same as Medicaid. A couple big differences are Medicaid will provide transportation, to and from your doctor's appointments. The Basic Health Plan will not. The Basic Health Plan will not have adult dental. And I feel like there's one other thing that I'm not thinking of right now. But it will also be a coverage option that does not have the premiums or cost sharing, because that is actually handled through. This is an area I don't know a lot about, but the federal government essentially gives some funding to the exchange, and then that allows the cost of the coverage to be taken care of. So what we're working on between us and DHCF and the Health Benefits Exchange is that we'll identify the folks that may not meet the new eligibility requirements. We will share that with the exchange, and then they will do outreach. And then, all goes according to plan. It will be a seamless transition without folks having to do something. There's a small group of folks with incomes above 200% of the poverty level that won't be eligible for Basic Health Plan, because that's the eligibility requirement set by the federal government. And then the option there will be going to what's called the marketplace or the Health Benefits Exchange or DC Health Link. And the option will be to purchase coverage that has some kind of tax credit, but will definitely be a change from almost no cost on Medicaid to a coverage option that you'll have premiums and deductibles and copays. So I hope that helped. I did want to call out, there is a basic health plan advisory council that's meeting Monday evenings. In a moment, I'll pull the link over from the HBX website and put it in the chat. And so if that's something you're interested in learning more about or hearing about, that is one place to do so.
Thank you, Melissa. So yes, again, if you all have any questions, please feel free to reach out to Melissa. I know I did say we're going to go into a little break. We're not, but feel free to take care of yourself, step away, as you may please. So without further ado, we'll go into our second panel, and Melissa did a beautiful job bridging the gap because I know that Jen will get into Alliance and speaking more about that. So we will have our second panel.
Before you start, can I do 2 poll questions before we get into Jen's?
Yes, go ahead.
Take Melissa off the spotlight. And so let's go here. Just try to make this quick if I can figure this out. Okay. So the question is, are you or someone you know currently enrolled in the DC Health Care Alliance? Okay. So we're looking like majority of people that have answered the poll have somebody, and some people are not sure, likely because they may not be familiar with what the DC Alliance is, and a couple said no. So I'm going to end this poll and then share one more question for now. And that is, what do you think makes the DC Alliance program important for DC families? It covers people who don't qualify for Medicaid. It helps undocumented or mixed status people. It makes sure everyone gets primary care, or I'm not familiar with it yet. Okay, so it looks like we're at 55%. Please keep answering. Majority of people, at 4 people, says it makes sure everyone can get primary care. That's a good answer. And the next popular answer is it covers people who don't qualify for Medicaid. Okay. And a few people are not familiar with it yet. So this is the right place to be, particularly for those who may not be familiar or understand the impacts that this has. And I'll pass it back to you, Danny.
Thank you. Yes, so I am very excited to welcome Jen. They have been doing an amazing job supporting the Alliance group that we're meeting every Monday at 1 p.m. So shout out to everyone at the group. But I would like to introduce Jen. Jen Jenkins is a policy manager and lawyer at Legal Aid DC. Their primary focus is advocating for systemic reforms before the DC Council and other government bodies with respect to Legal Aid DC's practice areas. Prior to joining Legal Aid DC, Jen worked in state government for the Office of Hawaiian Affairs, where they testified and advocated before the state legislature, drafted legislation, and served on the state integrity
Interagency on Homelessness.
Interagency.
ICH.
Interagency Council on Homelessness. So, Jen, we are glad to have you, and I'll pass up the mic to you to go ahead and give us some opening remarks.
Daniela, thanks so much to you and the Health Justice team for having me. Like Daniela said, I'm Jen. I'm a policy manager with Legal Aid DC. I also live here in DC in Ward 7. The way I view my work is to ensure that the DC's most vulnerable residents are centered in our policies and protected in our budget. And I will actually probably touch on the budget a little bit during this conversation, just because it's directly impacting the Alliance program. And just a little bit of background on Alliance. It was formed in 2001 after the closure of DC General Hospital. And what it really aims to do is provide healthcare coverage to people who don't qualify for Medicaid. And that does end up being like a certain group of people. But right now, what's happening in the budget is some pretty big changes to Alliance. A lot of people are going to be losing coverage beginning on October 1st. And it's been a pretty tough pill to swallow this entire budget season, which I've been through a few now, and arguably this might be the worst. And just so if you don't know, so Melissa was talking earlier about the big beautiful bill that's the federal level, but there's the DC Council. So they make determinations about all of our local laws and the ways that where money will be spent. And then so up until this budget, Alliance was always in a pretty good position in terms of the types of care that people were receiving in this program, and like their ability to access care through Alliance. And yeah, all of that is very much in jeopardy right now. And the reason that it's so important to legal aid is because they make up, the people who participate in Alliance make up a significant portion of our client community. So we're literally going to be watching people get sicker unless the DC Council decides to change their minds ahead of this upcoming final budget vote on Monday. So that's my introduction.
Thank you, Jen, and thank you for keeping it real and just sharing all of the things that are currently going on and continue to affect the communities in DC. So let's take it back a little bit. Let's get to know a little bit of the background. Could you share and walk us through the origin of DC Healthcare Alliance and what was the purpose of it forming after the DC General Hospital closure?
Sure. So after DC General Hospital closed, it basically left a huge gap in care and health coverage for people who are low income or underprivileged in DC. If you don't know, DC General Hospital was the only full service public hospital in DC before it closed. So basically, providers were like, we need this group of people needs coverage, and the Alliance program was formed as a result of that initiative. Yeah, there wouldn't have been, if it wasn't for this coverage, there wouldn't be, like, everyone who lost coverage under DC General wouldn't have had any other option, essentially.
Thank you. So could you talk about how has the program evolved over the past 2 decades?
Sure. The right when it was first formed, it offered very basic services. It's actually, Alliance has grown a lot in terms of the type of care it offers, as well as the way it is administered. So for instance, now there's it covers certain behavioral health needs. There was a point in time when Alliance required face-to-face recertifications and 6-month recertifications that required people who were trying to access healthcare to stand in very long lines really early in the morning on the off chance that they might be able to receive care. That was eliminated. Like I said, behavioral health services were somewhat expanded, as well as mental health services. All in all, it's very much grown to be a much bigger program. So there was a point in time when Alliance kind of shrank in terms of who it served. That was right around when the Affordable Care Act became law. A lot of people were able to transfer over to Medicaid. And so with this shrinking, there became more of a concentration of undocumented residents who were receiving care. And that's, since that time, that's kind of been like the majority of people who have received Alliance services. But undocumented people aren't the only people who receive Alliance. So it's just truly anyone who doesn't qualify for Medicaid, and that can include a range of immigrant statuses. And yeah, that's.
And Jen, thank you for noting that. That leads into my second question. I mean, my third question, but also the point of it served a lot of people and different communities after the hospital closure, and slowly it has evolved into serving majority, some of the immigrant population in DC, but not solely them. So, for those who are unfamiliar, can you share how Alliance differs from Medicaid or private insurance? Who does it serve and who is left out?
Yes. So, like I said, Alliance really has evolved to the point where it's people who benefit from it the most are undocumented, but it's not just undocumented people who can receive Alliance. Um, it says in statute, it's basically anyone who doesn't qualify for Medicaid. So that can be any person if you aren't able or eligible for Medicaid for whatever reason, due to income or yeah, there's a range of reasons why you may or may not be eligible. You could be eligible for Alliance. To be eligible for Alliance actually has a stricter income restriction. It's 210% or below the federal poverty level. So you just can't make more than that, and you can't, as well as not being eligible for Medicaid, and you should be eligible for Alliance. Alliance, the type of services that Alliance offers are not quite as they aren't on par with Medicaid. There's just like certain there's like dental caps and other it's just not as comprehensive as Medicaid. So it's a great program and we definitely want to keep it, but I think it could be expanded even more if the district was willing to invest into it. And just I hope I answered your questions. Oh, and then yeah, there's just other different types of restrictions too. So it just has like a smaller provider network. It just benefits aren't as robust, but it still provides a lot of essential care. And I would honestly love to see it expand more to be more like Medicaid.
Yes. And Amy made a great point that it sounds like a little bit of Maryland Medicaid and how they don't offer dental. So I know you spoke a little bit of the services. Can you expand on, especially with the changes going on? And I know DC Council is still voting. I know that the first vote, they made more suggestions on Alliance. So can you share a little bit about what kind of services does Alliance cover or will be covering? And how is that affecting the health outcomes with the residents of DC?
Sure. So right now, just a little bit of background on the budget, so we're all on the same page. Basically, what happens is the mayor, the executive branch, and DHCF propose a budget. They transmit it to the council. So there was like the mayor's version, which was actually and sorry, present company. It was it was in a worse. It was pretty bad. It's in a much better place now. After having gone through a bit of the budget process, the health committee addressed some of the issues with the proposals, which I'll get into. Essentially, at least from legal aid's perspective, one of the worst changes is the drop in uh, the federal poverty level income requirement. So I said earlier that right now it's 210%, but if the council votes on Monday to keep it as is, it'll change to 133% of the federal poverty level. And so that means that anyone who is above 133% on October 1st of this year could potentially be cut off from Alliance just due to their income alone. So severely reduced eligibility level. And it's also my understanding that DHCF doesn't even plan to verify. I don't know whether or not DHCF plans to verify if people's incomes have changed. So usually there's a recertification period that a person will go through and they can, they have to show that they're still eligible for our program. But our current understanding is that on October 1st, it just doesn't matter if there is a verification or not. It's just people will be cut off if they're assumed to be over 133%. So that's a pretty bad change. Another really major change that will result in huge drop in coverage is limited enrollment for a certain age. So when the mayor proposed her budget, it was a cap of at the age of 21. People can no longer enroll if you're at the age of 21. It went through the health committee, and now that age is 26. So if you're trying to enroll in Alliance and you're over the age of 26 after October 1st, you will not be able to do that. There were proposed changes to bring back the 6-month certification, to bring back the face-to-face interview requirements, which I thought, I think it was Councilmember Nadeau made a really good point that we're going to be exposing a large group that's predominantly immigrants to face-to-face interviews, which means standing in long lines at ESA when we've seen all of these issues with ICE just taking over the district and beyond. And so that was another major concern, but the health committee did fix that. And I should also mention that there's Alliance, but there's also something called the Immigrant Children's Program. And so this is a program for youth and children that's on par with Medicaid. So I said that with Alliance, there's like a couple restrictions, but with this youth and children's program, they have amazing coverage, just like Medicaid. They're now going to be transferred from the Immigrant Children's Program to this, what we're calling like a quote unquote new alliance, where we don't expect them to receive the same quality of care that they had in ICP, but other people are claiming otherwise. So I guess that's something that we'll have to see as things play out. And like I said, yeah, we know that the coverage will just not be what it was. And we know that for the people who stay or are able to stay, who do somehow meet these new eligibility requirements, but for the people who just are cut off, it's going to be a huge shift in what they're able to access, because they just really don't have anywhere else to go that for someone who's low income. And there was a lot of confusion around this group of people being able to go to the basic health plan that Melissa Bird was just talking about, but that's just, there's a very small group of people who may or may not be eligible. But the majority of people who will be cut off won't have anywhere else to go.
Thank you for touching on the Immigrants Children's Program. Just so that people know, Chioma did an amazing job working on the Health Resource Manual, which provides a lot more detailed information if you're not familiar with the program. So feel free to check that out also on our live binder. And Jen, you mentioned they would be transitioned over. Does it have a program officially, a program name officially, or not yet?
It's called Alliance. It will still be called Alliance unless they decide to change the name. But essentially what's happening is they're completely eliminating the Immigrant Children's Program and just combining everyone into Alliance. And then in the year 2027, we will see Alliance be canceled for anyone over the age of 21. I'm very emotional about this, so I'm trying to be as professional as I can, but it's very upsetting for me.
Sorry, go ahead.
I see a raised hand. I want to
Thank you. This question is actually for either one of our healthcare champions. I recently read an article that stated Trump has given ICE access to all Medicaid recipients, contact information and addresses. Is this something that is being discussed within your agencies and organization? Okay. Yes. Okay.
I'll pass this over to Melissa, but we haven't been talking about that in particular right now.
Thanks, Jen. And please, I wanted to stay on just to listen to the conversation. Don't feel the need to, I'm not going to be offended by what you say, I guess. Please feel free to talk as you wish, Jen, on the changes that are out there. So what was reported by the Associated Press last week, I think it was, I can't remember, was that yes, supposedly there is some kind of memorandum of agreement that on the Medicaid side, the federal Medicaid is called CMS, the Centers for Medicare and Medicaid Services, that Medicaid, so CMS and ICE have entered into a data sharing agreement whereby CMS will share the Medicaid data with ICE. I think it's on like a limited time basis over a few months, and to other details, I'm not sure. So what I can just tell you is that every state and district in I think most of the territories, we provide data to CMS on a monthly basis. It's just regular reporting. It's not anything new. So they do have access to something that's called TMSIS, and that's how the federal government collects Medicaid data to inform their policy making. And so what's alleged is that Medicaid or CMS is sharing that data. So I don't have anything that confirms that. What I've seen in the papers is I've gotten the same news that you have on that, Fari. But I would just say it's not a new exchange of information or a new data request that states got. It's information that CMS already has access to.
Jen, I hope that didn't make you more emotional.
No, everything that's happening federally is a whole, bleep show. So I'm already emotional about that on
Me
top of
too.
everything else. So
Me
thank you
too.
for the question. It's important to ask.
Yes. Shout out to you, Fari. I knew you had a question there. That's why I said, Fari, go ahead. Go ahead. Thank you so much, Fari, for bringing that up. It is very important. And I also think, as Jen was sharing about the in-person certification and having to do that every 6 months. So just to be clear, Jen, that won't be a requirement in person anymore? Or we have
It's
to
just
wait?
going to stay the way it was. So it's not a requirement now. It was proposed to change back, and it's not going to happen. So that's one good thing. That was changed by the health committee.
Okay. So let's dive a little bit deeper into DC Council, especially for people who may not be as familiar. And Chioma, thank you for sharing that resource in the chat. You can see that she shared some one-pagers about DC Council. So can you explain a little bit about the responsibility that DC Council plays in protecting or expanding the alliance for the year of 2026 and that budget there?
Yes. So the council has a pivotal role in determining what will or will not happen with alliance coverage. Like I said earlier, the mayor transmits her budget, but it's a proposed budget. So the council can do what it needs or wants to with it. The budget that was proposed essentially asked the poorest people in DC to pay for the budget, essentially. So there were slashes to programs like Alliance and other safety net programs like TANF, emergency rental assistance. So the council was received this FY26 budget and had a lot of big holes in it. And it but it's not, the council isn't without options. There are ways to fill these holes and kind of like move money around within their committees. And so what happened is like a lot of the committees found ways to like fill some of these holes, the lesser expensive holes. But with Alliance in particular, there was like kind of two sets of changes. So there were these statutory changes. Some had what's called a fiscal impact, and some didn't. And then there was just like line item changes. So it meant that Alliance was just going to switch to fee for service. It meant that FQHC, something called FQHC rebasing, was defunded. But that wasn't in what's called the Budget Support Act, where a lot of these statutory changes are happening. And that's where like these dates are coming into play. So like this October 1st date that I mentioned about that changes the eligibility level to 133% of the FPL, federal poverty level. That date is in this written statutory budget document. And so what the council can do is it can amend this statute because that's part of their power, their legislative power. So if they amend something within the statute, they have to find a way to fund that amendment if there is like a fiscal impact that's associated with that change. And so we in the Monday group, that huge group of amazing providers and neighbors and lawyers and organizers, everybody under the sun, everyone in DC who wants to fight for this program. Basically what we've been doing is trying to tell the council to push back the changes by 1 year. So which would cost like $48 million, which, I mean, if you've heard about the stadium at all, our tax dollars, if you live in DC, it's like $500 million going to these already, I think, millionaires, if not billionaires. And so we're saying we want $48 million in this Budget Support Act to just hold off for 1 year. So we can form a working group. We want to work with DHCF, which is also part of why I have a lot of emotions, but I'm not trying to burn bridges. And so we want to work with DHCF. We want to work with Councilmember Henderson, and we want to form a working group to really like take a longer view look, a more holistic look, instead of just saying, all right, we're just going to cut all this stuff and we're going to raise $48 million in fiscal year 2026. And all these people are just going to be thrown off their health care as a result. Like we just think there is another path. But right now it seems like the council is kind of throwing its hands up and saying that it wants to wait until the fall because there's going to be this other part of the budget. And I'm so sorry I'm talking so much about the budget, but there's this other thing called like a supplemental budget that will come up because of something else Congress did where they took our money. And there's also some other things where like the laws need to align with tax stuff. I won't get too into it. But essentially the council does have one more vote on Monday, and that is their opportunity to pause these drastic changes. Like I said, the alliance has been around since 2001. So, and the council has a 70-day period to go through the budget process. So a 25-year health program that sustains the lives of 27,000 DC residents will effectively be limited in terms of services, cut off people in terms of eligibility based on their age and income, and with barely any notice, because like I said, this is like a 70-day budget process. And the council has been made fully aware of this. We've brought these issues to their offices. Honestly, at this point, it feels like daily, but at least weekly. And they have a choice. They have an opportunity to make a policy choice. There are plenty of places to get the money to fund the program for 1 year. And I will stop there.
Please do not apologize about speaking about the budget because it matters and there is power in the voices of advocacy members. Every single person in DC that is a resident living there, experiencing all these issues, paying taxes. It is not something that you are going to talk too much of because it matters. So thank you. And as I also know that Chioma in the beginning was shouting out our parent ambassadors, part of our health policy camp, and majority of it, actually, not part, majority, is this framework of training and providing different advocacy skills, leadership skills, and knowledge to our parent ambassadors, primarily to be advocate leaders in our communities. So thank you for sharing about the council, Jen. And I want to ask next, what are some of the advocacy strategies that are actually working? You mentioned going in and speaking with council members. What works? What do you see that in terms of organizing, this is what we need?
Yeah, so usually normally our tactics work. I have to be honest, this has been one of the strangest experiences in my advocacy career. And I've had some pretty weird experiences, particularly within the world of health laws in particular. Um, and I have to say that I think I can talk about what doesn't work because it's still sore right now. But I think that we were kind of we were caught off guard, and we didn't need to be. Alliance has been going, so like we got the recertification changes and the face-to-face changes a few years ago, and like that was one of the last big pushes that we needed, like as an advocacy community, that we were really trying to make. That was I think it was a decade-long fight, if I'm remembering correctly, maybe a little over, like 13 years. And so we were kind of caught flat-footed, and I don't think that we were coordinated or prepared enough as like a community to kind of to fight in the ways that we could have, like strategize and fight in the ways that we could have. Like we're doing everything right. Like I said, we're having those meetings. We're using all of our personal relationships with these council members. We're making sure people are sharing their stories. So that the harm is very real and human. We're not just talking about numbers. It's not just 27,000 faceless people. It's like, we're going to the Wilson building tomorrow and we're going to have a person who's pregnant and an Alliance recipient there. Like this is a real change. So we're doing, like, in my opinion, we're doing all the right things. I think that maybe I would caution overestimating the amount of compassion that some people might have, because I personally, like sometimes it's easy to make the mistake of operating from your own moral compass when others may not. You assume that they would want to do something that just seems like sane, but that's not necessarily true. People have different values and like motivators, and so I think like if we had, just anticipated this a little bit more, we could have probably evaluated the landscape a little bit better. Um, but yeah, it's just like with healthcare in particular, it's very, I've found it just to be a very tricky area to advocate for, because the type of lobby it's a really complicated subject matter. And if you are trying, like I said, this is a 70-day budget. And something that's also another kind of like issue at the council is there's a lot of high staff turnover, and then the council members don't know everything. I think they would admit that themselves. And so it's like, we need to educate you on one of the most complicated areas of law. And we need to do it in 70 days, and you think it costs more than it does. And it's just like a lot of things. So if anything, I wish that we had still had like a good, like strong alliance coalition going. And I know that we have that now. And like, I know that we're not going to give up, and I know we're going to keep like fighting for this. But it's just like, oh, I wish we had it like more established and sooner. We just didn't really see this drastic of changes coming.
No, for sure. And I am so grateful that the group is there, that there are so many people in the front lines and definitely supporting that the best that they can. I'll tell you this, I'll brag about the Alliance group because they have many people up in that Wilson building. And so far that Jen is saying continuously, I think we have enough. So I do appreciate you touching on the fact as well, just the moral compass of different members and kind of wanting to get a gauge on that earlier, or hoping to know that sooner to get better landscape in the advocacy that would precede that. But as we are coming towards the end, I just wanted to give it back to you, Jen, if you had any other final remarks. Specifically, I know you made the plug about Wednesday, tomorrow, people will be going. Moving forward, what could advocacy continue to look like despite the vote that would happen on July 28th?
Yeah, I think that we need to keep our group going, and really just kind of map out how we want things to change with Alliance. I think that another kind of thing that was worked against us was we don't have like really comprehensive data on the people who are being impacted. Like we don't have access to it. I know it exists, but like breakdowns of ages and things like that. And really good storytelling would be good too. So I think that we just have to build out a real campaign. And I definitely invite anyone who's impacted or cares about this issue to work with us. We did and still do want a working group, like a more formalized working group, but if we have to do it on our own, we have to do it on our own. And when I say more formalized, I mean like working with government agencies. These type of working groups exist for things like TANF, changes to TANF, and other public benefits. And just really to use the expertise, like one of my colleagues, Andrew, who actually couldn't be here, he's been working on Alliance issues for like over a decade, and he has so much knowledge about this area. Honestly, the only way I can confidently talk about it is because I'm able to pick his brain as a colleague. And I just think that but he also has that real life experience of all of his clients are like could be cut off. And I think that a lot of that was just missing from the conversation. So I would just want more collaboration instead of just being thrown wild budgets that just are like, oh, people are gonna die, and that at least we saved some money. Yeah. I hope I answered your question.
No, you did. You did a beautiful job ending, and like I told you from the beginning, keeping it real. So thank you, Jen. We truly, truly appreciate all your efforts, and thank you for everything that you contributed with us today. I really appreciate it, and I love the chat, how it's going off, and all the reactions that I'm seeing. So let's continue to build the momentum. I'm going to pass it back to Chioma to just follow up with some questions.
Okay, this is the last time you're going to hear from me with our last two poll questions. And let's see how quickly I can get these up. All right. So the next question here is, after this session, how likely are you to talk to others about protecting or improving the DC Alliance? Okay, this is what we like to see. We like to see the options are very likely, somewhat likely, not likely. I still have questions. And so we have majority 7 out of 10 so far, 11 now. 8 people are saying very likely, 3 people are saying somewhat likely. So we have people ready to get on board with the coalition efforts here to save Alliance for all the vulnerable Washingtonians that need it. And I'm going to end this poll. Thank you all. And share these results. And then the last question is, what kind of actions would you feel comfortable taking to support health access for immigrant families? Signing a petition or emailing DC Council, attending a rally or town hall, sharing more information with friends or family, testifying about your experience, or you'd need support or training first. In a minute. All right, it looks like majority of folks so far. Please keep responding. We're 62%. We'd love to get to 75.
Chioma, I don't have the poll.
Oh, it should be on your screen. And if it doesn't show up, maybe you're on the phone. So don't worry about it. I don't know how else to share it.
I do want to make a note. So Fari, on your phone, there's the 3 dots. If you click on there, there should be a tab that says poll. Sometimes on your phone, it doesn't easily pop up, but hopefully with that, it lets you see it.
And I would just read the results for this. We're at 81%, so this is great response rate for this one. And it looks like majority of folks at 5 people prefer to testify about their experiences. Next popular response here is signing a petition or email. And then there's also equal need for support or training first. And we are very happy to help with that. So I'm going to end this poll and share the results. We will be doing one-on-ones after. We do have some panelists that want direct feedback, so we do want to engage our ambassadors particularly about what your thoughts are. And I see Linda's hand up, so I'm gonna spotlight Linda. And I am done asking questions. Thank you for your patience.
Passing it on to you, Linda, for any questions, and audience as well, any questions you have.
Linda, do you mind coming on camera so I could spotlight you? If you're able to.
Second. And actually it's I just wanted to make a statement and ask a question, really. I just wanted to say to Jen is that I can feel how emotional this is. She's crying. I am pissed. I am so angry. So it's about the same because I wanted to know, you just built a hospital in Southeast, replacing Southern. How do you expect people to pay for hospital visits if their insurance isn't there? So the hospital is just going to remain vacant and no one's going to use it because they don't have the funds to pay for it, because no one's going to have insurance. Yeah, that's just wanted to get that off my chest. You built a new hospital for supposed to be for low income people, and you're taking their insurance away so they can't go and see a doctor. Yeah, just doesn't make any sense to me.
Yeah, they got to build a stadium, girl.
Yeah, but you already built the hospital. That's crazy. And now you're going to take their insurance away. Jesus. I'm sorry. I'm angry. Just
No,
wanted to get that off.
and thank you, Linda. No apologies needed at all. We welcome the space here. Amy, go ahead.
Hey everybody. So, and I'm driving as always. So to piggyback off of the comment about the stadium, so you see how they try to wrap in that they're adding homes and other things that's connected to the stadium if it's built to make it feel inclusive. And I don't know if they wrap that in to make it as if it's not another thing, but trying to wrap the community in so they can accept another stadium in DC. You got and you have RFK. You have all these arenas around. You got people. We don't know. People are homeless. People getting evicted. There's so many different things going on. They putting big business in front of humanity in DC, and I don't get it. It's crazy.
Definitely is. Chioma, I do want to pass it back to you just for some closing remarks. And I know you shared something in the chat, so feel free.
So yeah, so thank you all for your time. I totally hear you. Amy, I hear everybody. I'm right there with you. But just given that we presented our community needs assessment at the Ward 8 Health Council, and there were folks from the mayor's office that this is how they framed it in terms of the need for the stadium is that DC will not have revenue. We do have $1.1 billion that we still, from this current operating budget that was seized from us, we are uniquely vulnerable. I'm not saying that we need to sacrifice people's lives, but I think as a city, there is a way that we probably should start thinking very intimately about how we collaborate, because we're going to need each other regardless of our value system and interests and all of that, with consideration that we have a common enemy, and that is what's going on in Congress right now. So I want us to kind of keep that in mind, just to give that perspective. And, thank you all. I mean, I am as directly impacted as everyone else on this call. I am very afraid for my children's future. But we must do more than be afraid. We must organize. So we hope that this is just one small step in a direction where we start to come together. As Rhonda said, we do have a family support council. We have other avenues in which we will be calling on our village to come together. Those who are not in disability spaces, we need to, widen the tent. Now, more critical than ever, we do need to come together. And I hope that we as family leaders can take up that space. I believe very much in the power of caregivers and caregiving from a matriarchal perspective, that we have a unique political power that we can leverage at this time for visioning the future that we deserve for all of our citizens here in DC. So on that note, we hope that you all join us on Thursday for the workshop on youth and transitions, as well as our mutual aid. We do have a toolkit in the live bander that you also see on peer support, mutual aid, things that we're dreaming up internally that we hope to manifest in the community. And we hope that others take it and implement it before we do. No competition, only complementation. So we hope that we come with our thinking hats on Thursday. Think about what mutual aid can do, because we truly can only keep ourselves safe. I fundamentally believe that. So I will pass it back to you. Emil, Emil's part of our team. The reason why our parent organizers are here is because of Emil. He's the quiet member on the team.
Yeah, no,
But
I've been letting y'all talk
thank you.
and get it out, but it's been, it's beautiful and scary at the same time. It's beautiful to see y'all on this call, the fact that we got everybody together. But Jen, I definitely feel you. I've I've been more than scared, especially, me having Asian parents, and also, you know, having my friends, a lot of them, being undocumented. It's a weird, yeah, I don't know. It really is no words for it. But y'all give me hope. I can't lie.
Back to you, Danny. That's my closing. I don't know, Jen. If there are ways that you feel free to drop any link, any petitions, anything that you think folks can sign now, and we'll be happy to share those resources afterwards if they're not available as well. But thank you for sharing your passion and knowledge with us. All right, and we'll see you all Thursday. We will stay on. Oh, Emil, if you could please drop our evaluation in the chat. So we do have a formal evaluation, and there will probably be another evaluation that's going to pop up after you you end this meeting. Zoom will pop up one. Do apologize for the multiple written evals, but we will appreciate your time to complete it. We can stay on a few minutes longer so that, give people a chance to fill out their evaluations. They help us kind of estimate what we're doing here, how we can do it better. So so please do that, and we will see you all Thursday. Thank you.
Renee, I'll let you ask your question, but Emil, really quickly, I already put the question in the form in the chat.
Oh, you already put it in? Okay.
Yes. No worries.
Cool.
Renee?
You're on mute, Renee.
Sorry, for the interruption. Oops. Can you hear me now? Basically, I'm on my son's iPhone, and I can't access I might not be able to access the exit information. This is what I mean by sometimes I have to use multiple devices in order to log into the meetings. Can someone, or anyone from the team follow up with me in the morning so I can make sure I have all my stuff turned in? Thank you. Anybody.